7D7. We are here today to present to you a friendly debate discussing the importance of intraoral and extraoral radiography. Radiography is a vital tool which aids in the diagnosis of dental care, ultimately developing a personal treatment plan for each patient. Intraoral and extraoral radiography have both pros and cons associated with each. We are first going to discuss the field size with regards to what type of radiographs would be most effective. We will then discuss the errors associated with each type of radiography. Finally, we will discuss patient comfort and the cost differences between intra and extraoral radiography. Farah and I will be discussing field size first. Extraoral having a larger field size and intraoral having a much smaller one.
Intraoral radiographs provide a lot of detail because of its smaller field size. These radiographs are used to identify problems with individual teeth. Intraoral radiographs provides much more detail when it comes to detecting cavities on the tooth, in between the teeth, and the health of the roots. This is because of its more magnified view compared to extraoral radiographs.
Extraoral radiographs do not provide the detail that an intraoral does due to the larger field size. So rather than being used for identifying problems with individual teeth, it is used to identify problems affecting the entire temporomandibular region. This includes impacted teeth, growth and development, trauma, problems between the teeth and jaw, as well as other bones of the face. The most common technique is a panoramic X-ray, which produces a single image that includes both the maxillary and mandibular arches and their supporting structures. The panoramic radiograph shows the bone, sinus, and the mandibular nerve, while the intraoral radiograph will not.
Well, intraoral radiography also have a wide variety of dental radiographs that can be used to detect structures and other conditions of the teeth depending on different situations. Most common are bite wings. These types of radiographs show details of both upper and lower teeth of one area of the mouth. It also shows the details of the crown of the tooth and the supporting bone level. They are used to detect decays on different surfaces of the tooth, including the interproximals, which is hard to detect on a panoramic radiograph because of its less magnification.
With this enlarged field size, an extraoral radiograph can be used as a screening process to identify disorders that may be the source of TMJ. To view what may be causing this disorder, a radiograph has to show the entire joint as well as the surrounding structures. The enlarged field size can also be useful to show if any cancerous lesions are present. The cancer could go undetected on the intraoral radiograph, but will show up on the extraoral radiograph.
Even though TMJ screening and cancerous lesions cannot be detected on an intraoral radiograph, there are things that will show more clearly on an intraoral and will not appear properly on an extraoral radiograph. These include more wide details of the apical portion of the tooth that can be seen using the periapical radiograph that also show the wide anatomy of the tooth. Periapical radiograph shows the full dimension of the tooth, both upper and lower, that are used to detect any abnormalities of the root structures, like an abscess on the apex and the surrounding bone structure. Therefore, intraoral radiographs do have a small field size, but provides a lot more details than extraoral.
However, having a larger field size shows both arches and their supporting structures, which is also essential.
Barbara and I will be discussing the errors associated with each type of radiography. Especially with intraoral radiography, there are many errors that can occur during its long process. The first error, which is easily solved by the advanced techniques of a panoramic radiograph, is cone cutting. Unlike a bite wing or periapical, a panoramic radiograph is more effective because the X-ray tube head rotates around the patient's head, receiving a full image without any cutoffs. Unlike an intraoral radiograph, where it is easy to not place the PID exactly over the receptor, or for the patient to not understand where they should be kept their head positioned, causing them to damage the end result of a radiograph.
Well, cone cutting happens within intraoral radiographs because the PID is not directed at the center of the receptor, and the X-ray beam does not expose the entire receptor, causing an unclear, unexposed image. This can easily be corrected by positioning the PID carefully, making sure that the X-ray beam is centered over the receptor and that the entire receptor is covered by the diameter of the PID. This is an easier skill to learn rather than the positioning of the panoramic machine because although all proper procedures are done, there is still the risk of distortion, improper magnification, and even overlapping simply because the machine's default.
Speaking of defaults, there's an error called phalangioma, where the image of the patient's fingers is seen on the intraoral radiograph because it was positioned incorrectly in front of the receptor instead of behind it. As a result, seeing the image of the bone of the finger in place of the anterior teeth. This is not a problem for extraoral radiograph since the patient's hands are placed in a specific area away from the receptor.
That method is not recommended or used anymore, therefore this holds your point invalid. A second error that is often made by clients during a panoramic process is if patient's lips are not fully closed on the bite block during the exposure of the panoramic projection. It will result in a dark, radiolucent shadow on the anterior teeth. If the tongue is not in contact with the palate during exposure of panoramic projection, this will also result in a dark, radiolucent shadow that will make an unclear image of the apices of the maxillary teeth.
Although the tongue and lips are a factor that can impair the radiograph, it is easy to resolve because the client will be instructed to swallow once and then asked to raise the tongue up to the palate, which are simple instructions that the patient can do rather than focusing on more than one thing, such as proper biting techniques and holding their head in an exact position without any support.
Amanda and I will be discussing patient comfort when taking extraoral radiograph and intraoral radiograph. Extraoral radiography is better than intraoral radiography. It is more comfortable for the client to take extraoral radiographs because the client is only required to stand still for about 30 seconds and bite on a bite stick in case of a panoramic radiograph.
Well, intraoral radiograph can be more comfortable for your client because some patients are unable to stand for any length of time. For example, some clients who are in a wheelchair or use a walker or a cane cannot stand for long periods of time. Also, clients who may suffer from certain diseases, such as Parkinson's, will not be able to stay still for any amount of time it would take to expose a panoramic or a cephalometric radiograph, therefore resulting in a blurry, undiagnosable radiograph and exposing the client to unnecessary radiation.
Taking an intraoral radiograph requires a film to be inserted in a client's mouth, which causes moderate to extreme discomfort to the client. Extreme discomfort may result from some oral anomalies such as mandibular tori and macroglossia, and some conditions such as sensitive gag reflex and severe anxiety.
Well, an option for clients who find discomfort with intraoral radiographs because they suffer from a dental anomaly such as mandibular tori, you might want to try using a smaller size film for their comfort. Clients who suffer from a sensitive gag reflex, you can try giving them salt on the tip of their tongue to distract them, or asking them to breathe through their nose and wiggle their toes. This would cause a distraction for the client, helping to ease their anxiety.
Another concern is that the chances of client getting exposed to more radiation is greater if intraoral radiography is used for complete assessment because it will require taking a full mouth series of radiographs exposing patient to 0.06 millisievert as compared to taking one panoramic radiograph exposing patient to only 0.019 millisievert.
Yes, but in regards to exposing the client to 0.06 millisievert, intraoral radiographs would be used for a different purpose than an extraoral radiograph. It is not always necessary to take a full mouth series. 4 bite wing radiographs will only expose the client to 0.038 millisieverts. Acquiring the correct prescription would eliminate the possibility of overexposure, which would be proper practice.
Leah and I are discussing about the cost and space. Intraoral radiography are beneficial to dental professionals and clients. In an office setting, big or small, the requirement needed to have intraoral radiograph are less since the units can be placed in the room where radiographs can be taken and the processing unit can be placed on countertops and separate areas. It is less expensive than taking extraoral radiograph, and the cost of the machine ranges from $10,000 to $50,000.
Having extraoral radiography machines comes at a large cost. However, if you have the machinery in your office, you will not need to refer out for cephalometric or panoramic radiographs. The patients will appreciate not having to leave your office and booking a whole new appointment at a whole different office. If I'm a client joining a practice without extraoral radiography and the dentist recommends that I need a pan or a cephalometric, I now need to take another day off work, spend more time in the waiting room, and more money. If we as dental professionals are doing a good job on informing our clients to believe as well as we do about the importance of these diagnostic images, then it's a win-win. The client is essentially in better care as we can make a more thorough treatment plan.
But all dental offices need to have intraoral radiographs. You cannot replace intraoral radiographs with extraoral radiographs. It is a necessary component and an important diagnostic aid. There are different units available. For example, if dental professionals choose digital radiography or conventional, and the price ranges from $8,000 to $13,000. And for extra accessories such as for films, phosphorus plates, paper covers, plastic bags, fixer and developer range from $100 to $300 each. The cost of extraoral radiographs range from $50 to $100.
Yes, the cost of panoramic film can range anywhere from $20 to $50 per box. If your practice is charging $50 to $100 for one panoramic radiograph, you are making your money back. Also, most insurance companies do cover the cost of these images if they are necessary in the client's treatment. So at the end of the day, $50 to $100 is just as inconvenient as taking that extra time to go to a totally different practice for a new appointment.
Well, intraoral radiographs are inexpensive and can range from $10 to $80 depending on what needs to be taken. Film size comes in different sizes to accommodate children and adults. It also helps with clients who have different mouth size and opening. It is useful in giving information in diagnosing incipient caries, periapical lesions, and periodontal disease, which extraoral radiography lacks and has the ability to do. Extraoral radiography needs bigger space to accommodate a bigger unit, and most require separate room and sufficient space. But with intraoral radiography requires small space, the price is affordable, you get high quality at a low cost.
You're right about finding room in a dental practice for extraoral machinery. This can be challenging. However, once you do find the room, you will keep your clients. Keeping clients is what makes a successful practice successful. As previously stated, some clients will not be happy with having to leave and make a new appointment at a different practice. The client may not feel as important and end up leaving your practice. So, in conclusion, we have pointed out obvious reasons as to why both intraoral and extraoral radiographs are equally important. They can be used to supplement each other during oral examinations to aid in a proper diagnosis for your client's specific needs. The use of only one type of radiograph may not provide sufficient information. Therefore, it is necessary to determine what would best suit the client to avoid overexposure. Thank you.